Good afternoon, everyone, and welcome to the 6th edition of the Zero Dose Learning Hub Nigeria webinar series, brought to you by the Gavi-led Consortium of the African Field Epidemiology Network, AFINET, and the Africa Health Budget Network, AHBN. Here's wishing you a very happy new year, as this is our first webinar for the year 2025. We're thrilled to have you here once again as we dive into the theme for this 6th edition of the Zero Dose Learning Hub Nigeria webinar series, themed Advancing Equitable Health Access in Nigeria. This webinar series has consistently served as a platform for success stories that address immunization challenges across Africa. Today, focus on the critical need for sustainable immunization financing, particularly the evolving global health funding dynamics. Examine gender-related barriers that prevent children, especially those from marginalized communities, from accessing essential immunization services. Our expert speakers will provide valuable insights and practical strategies for strengthening a resilient and inclusive immunization system, contributing to Nigeria's progress towards universal health coverage. Before we move ahead, a few housekeeping items. All microphones are muted by default to reduce background noise. Panelists, please keep your microphones muted when not speaking. We encourage engagement. In the Q&A box at any time during the presentations, drop your questions there. They will be addressed during the discussion session, which takes place after both presentations. This webinar, for your information, is being recorded. The recording, along with the speaker presentations, will be shared with all participants via email. And active participants will receive a certificate and 5 CME points. With that, let's get started with a meaningful conversation on building stronger immunization systems for healthier communities. To begin, it's my pleasure to invite Dr. Patrick Nguku, the Regional Technical Coordinator, Anglophone West Africa, to deliver the opening remarks. Dr. Nguku, you are welcome.
Thank you so much, Margaret. I hope I'm clear. You can hear me?
Yes, sir. Loud and clear.
Okay. So, good morning, good afternoon, and thanks for joining us from different parts of the world. I notice we have now, I think, 52 participants, so I want to welcome you again to the 6th episode of the Zero Dose Learning Hub webinar series. We are delighted to have all of you here, especially our repeat attendees, and we look out for our events and make out time to participate. Over the past sessions, we've explored various critical themes, trying to touch on the most relevant topics with regards to immunization, particularly as regards zero dose and how to advance the equity agenda. So today's discussion is particularly timely as it touches on two very critical areas that directly impact the sustainability and inclusivity of immunization efforts in Nigeria. As we also recently, the funding landscape has shifted drastically, and so there's an urgent need to explore sustainable financing mechanisms for immunization, particularly increasing domestic funding for PHC and routine immunization. Equally as important is the need to look at the critical role gender plays in immunization access. So this webinar series has been a platform for engaging with others in the immunization space, fostering collaboration, sharing insights, strategies, and best practices for tackling the zero-dose challenges. And I'm sure the two key topics today, sustainability and equity, are very important issues to explore as we look for sustainable solutions to really reduce the zero-dose burden. I believe that everyone present is uniquely qualified to enrich the discussion, and therefore I join Margaret in asking that encouraging a robust discussion on the issues and deliberating on how to move the needle in terms of reducing the millions of children that we are not reaching with very key immunization systems. As always, we encourage all participants to actively engage, ask questions, share experiences that can contribute to this conversation. We look forward to an engaging discussion that will hopefully drive progress in immunization. And I really, really want to thank you and encourage your active participation. Thank you so much.
Thank you very much, Dr. Nguku, for setting the tone for today's webinar. Indeed, it is imperative to explore sustainable financing, considering the shifting funding landscape. Next, we have a welcome remarks and a short presentation from Erin Brookhuizen. Erin is the project director for Gavi Zero Dose Learning Hub project and John Snow Incorporated Knowledge Management Director. Since joining JSI in 2002, Erin Brookhuizen provides leadership, technical quality, and management of the Gavi Zero Dose Learning Hub project, a global initiative to improve immunization equity and reduce the number of zero-dose and under-immunized children. Erin facilitates knowledge translation strategies to improve data use and uptake to ensure high-impact evidence is used to inform immunization policies, guidance, and programs. Erin has led project implementation in over 50 countries. She creates environments for learning and collaboration and designs digital frameworks and tools to strengthen capacity and fill knowledge gaps. Erin, you're welcome, and over to you.
Terrific. Thank you so much, Margaret. Can you hear me?
Yes, I can. Go ahead, Erin.
Oh, super. Thank you so much. And next slide, please, Margaret. Thank you. So I'd like to thank AFANET very much for the invitation to participate today in this very important and exciting webinar. I'd like to thank AFANET and Dr. Yahaya and Dr. Patrick for the invitation. It's a pleasure to be with you today. I'd first like to just briefly talk a little bit about the Zero Dose Learning Hub and the Gavi model and sort of mechanism. I'd also like to dive in a little bit and provide a brief overview of JSI serving as the global learning partner in the Zero Dose Learning Hub. And I'd also like to dive in a little bit and talk about the important work and collaboration that we do with Nigeria, with AFANET, in addition to sort of some of the other work and things that we do across the 4 country learning hubs that we work with. So I'm super excited to be here, and thank you so much. Next slide, please. So first, part of this mechanism emphasizes country-led learning, and we also focus on local leadership through a country-driven and a country-specific consortia. Our approach does not only foster sustainability, but it ensures that interventions are aligned with each country's learning priorities and initiatives. The learning hubs that we work with generate evidence and fill knowledge gaps, identify barriers, make recommendations and approaches to overcoming challenges, and identify and focus on the importance of developing and supporting sound immunization strategies. We also focus on stakeholder engagement and look at really what the evidence is telling us in helping to drive decision-making and operational strategies from the global to the local community level. All of the learning hubs that we work with and sort of JSI and Gavi as we focus and implement this important initiative We really stress the importance of important feedback mechanisms and really key ways of identifying and adapting interventions, to move the needle and really move to sustainability and align with IRMA and Gavi's priorities around reaching zero-dose children in missed communities. Our country-led approach, we are driven by local leadership. From the evidence generation and use, we try to really emphasize a knowledge translation approach. We're taking evidence, how it's being generated and used, and really getting into the uptake and measurements to ensure that what we're doing and what we're learning is shared with the right people to drive change. As we'll hear extensively today from Afanet and from Dr. Garba and Dr. Bello, the importance of collaborative networks and looking at engaging the right people to inform decision-making is key. And this whole mechanism from JSI serving as a zero-dose learning hub global partner to all the country learning hubs we work with, we're very outcome-oriented, and we do align all of what we do and all of our priorities with Gavi's IRMA framework. Next slide, please, Margaret. Thank you. So the country learning hubs, this mechanism, we generate, synthesize, and share data and programmatic learning from a global to a country level. We're focused on really facilitating a deeper understanding of the factors influencing implementation and performance of approaches to reach zero-dose children and communities. And then we work very closely in collaboration with our country partners, such as Afanet, to support the Zero-Dose Learning Hub initiative. The 4 countries that we work with are Nigeria, of course, Mali, Bangladesh, and Uganda. Next slide, please. And as the global learning partner, we also, we take a step back and look at sort of synthesis across all 4 country learning hubs and looking at trying to identify sort of cross-cutting gaps and challenges to help develop and identify important tools and resources that can help inform and fill gaps, as well as working directly with each of the country learning hubs to help shape and use those tools and resources to help drive and strengthen the program implementation and research in country. So as the global learning partner, JSI serves as the prime. We started in July of 2022 with this mechanism. And at the global level, we have 2 other partners as part of our consortium. We work closely with the International Institute of Health Management and Research. They're based in Delhi, in India, IIHMR, and they support a lot of our theory-based evaluation and theories of change initiatives, and really help support the work we do in Bangladesh. Our other partner that I'm sure a lot of you might be aware of and maybe alum or part of the TGLF network, the Geneva Learning Foundation based in Geneva. And they serve they have focused on the peer-to-peer learning and really helping us develop some key knowledge translation and learning products. And as the prime, as JSI is the prime, we're managed by Gavi's measurement and evaluation learning team. And Heidi Reynolds oversees the mechanism and our work. We also focus on experiences and learnings from all 4 learning hubs. And we're really hopeful that as we're moving into Gavi 6.0, that the learnings, and the important work that we're all doing will help inform Gavi 6.0 and help shape, sort of what's coming ahead around program funding and guidelines. Next slide, please. So our demand-driven technical assistant approach is tailored to support the learning hubs, build capacity and capacity strengthening. We're focused on collaborative problem solving, and we really try to co-create and work side by side with our partners like AFANET and Gavi to help identify and overcome barriers and improve zero-dose interventions, based on evidence. And as I mentioned, sort of the knowledge translation components is an important component, especially as the learning hubs and AFANET, are implementing, collecting data, doing analysis, looking at what's working and sort of program findings, and then getting peer learning events like this one and how to advocate and push for change. So I think those are some really important elements of this demand-driven TA model. We also focus on LQAS. We've done some zero-dose costing work. We've done theory-based evaluation, and we work really in tandem and closely with our country learning partners. Next slide, please. In Nigeria, thank you. Next slide, please. So our work in collaboration with AFANET in Nigeria has been a wonderful experience, and I think we work really well in partnership together. So it's exciting to be with you here today. The Nigeria Learning Hub, and you may hear more or some of this today at some of today's sessions. We work in tandem and we work closely with the Nigeria Learning Hub. And the hub focuses on 8 LGAs with high zero-dose burden and overlap with 100 priority LGAs. We've helped, work with AFANET, in helping to shape and drive some of their approaches, protocols, and reports around decentralized immunization monitoring and the DIM report that should be coming out soon. With an estimate of 33% of children aged 10 weeks to 24 months not vaccinated with DTP1 across the 8 LGAs. Caregivers of zero-dose children face great barriers, continued low trust in health workers, showing a need for targeted interventions. And, the importance of data and data on zero-dose, including barriers and determinants. And AFANET is, been driven and working very hard on their rapid assessment, their DIM report, their implementation research report, which is also forthcoming. And so we, as JSI and the Global Learning Partner, help support and provide technical assistance and additional support as needed. Next slide, please. And I think my time is up, so I will wrap up here as quickly as I can. So some of the key work that we've been doing with AFANET has been around lot quality assurance sampling. I mentioned the LQAS methodology for the DIM initiative and approach. We've been helping around LQAS analysis and training of trainers and refresher training as part of data collection efforts in the 8 LGAs across 4 states. We've helped support and provide technical assistance for AFANET with the implementation research protocols and helping and advising and providing resources and support around sampling techniques and cost evaluation. And then we've led a political economy analysis around and really focusing on decision-making and immunization governance and looking at sort of the political landscape, across Nigeria. We've also helped support AFANET in planning their learning agenda workshop that happened previously. Next slide, please. And I just wanted to mention very briefly, next slide, please, Margaret. Thank you. So we also do a semi-annual update that we really help synthesize the work across the consortium, across the zero-dose learning hubs in all 4 countries. And we synthesize the learnings, we identify and look at and work closely with AFANET, and our other learning hubs to really look at what's the data telling us. We pull together a data dashboard. We look at brief highlights across the IRMA framework and looking at what is working, what are barriers that groups like AFANET and the other learning hubs are addressing, and ways that we can overcome challenges and recommendations for moving forward to support all the IRMA priorities and really build momentum and make changes to strengthen zero-dose interventions in countries. So we try to do a global synthesis for learning, as well as really then look at what each country learning hub is doing and synthesize their findings. So I would encourage everyone. We have a robust website that's part of the Gavi.org environment. So we are ZDLH at Gavi.org, and we produce a semi-annual update that has a lot of really rich information and really showcases and highlights the work that's been done in Nigeria, as well as across the other three learning hubs. Next slide, please. And there are just on our Zero Dose Learning Hub website, I would encourage everyone to visit the website if you can. We have a lot of rich resources that we've worked in collaboration with AFANET to develop, as well as I had mentioned, we have a zero dose landscape, situational analysis. We have a political economy a political economy assessment, and a lot of other rich resources that really showcase our global learning. We have some toolkits. We have a knowledge translation toolkit that's also available, and we will be developing a theory-based evaluation toolkit, an LQAS toolkit coming up. So we would just encourage everyone to please visit our website and access our tools. So next slide, please. Thank you so much. And I'm really excited to learn more and hear from the other presenters. So I will hand it back over to Margaret. Thank you, welcome, and super excited to learn more. Thank you.
Thank you, Erin, for your thoughtful and encouraging remarks. Thank you for that brief on Gavi and the Zero Dose Learning Hubs. And I'd like to acknowledge the presence of Reda Sadki, the founder and president of the Geneva Learning Foundation. It is a Swiss nonprofit research and development organization. Thanks for joining in, sir. And we acknowledge your profound commitment to racial justice, equality, and dignity in health. We probably might want to hear from you a little later in the webinar. Now let's move on to our first session for the day. It's titled Sustainable Immunization Financing in Nigeria, in line with the dynamic global health funding landscape. This session will be led by Dr. Aminu Magashi Garba, a distinguished public health advocate with over 30 years of experience in development work. He is the founder and CEO of the Africa Health Budget Network, AHBN, leading efforts in budget advocacy to improve health financing, transparency, and accountability across Africa. Dr. Magashi has played key roles in health sector reforms, serving on multiple national and global advisory groups, including Gavi CSO Constituency, Nigeria's Ministerial Swap Advisory Group, and the Global Financing Facility GFF Investors Group. He has been instrumental in shaping health policies, advocating for legislative reforms, and strengthening health security initiatives. We are privileged to have him share his insights with us today. Dr. Magashi, please take it away.
Thank you very much, Margaret. Are you showing the screen or out?
We will share your presentation for you.
Okay, thank you very much. So you can proceed.
Please go ahead.
With the first slide.
Sure.
Okay, thank you very much, esteemed experts, moderator, and remaining panelists and colleagues across JSI, Gavi, and AFANET. And also to welcome my colleagues from the Africa Health Budget Network across Nigeria in Abuja, Bauchi, Sokoto, Borno, and Kano. I'll be presenting on a very interesting topic, sustainable immunization financing in Nigeria in line with the dynamic global health funding landscape. Next slide, please. This is the outline of my presentation. I don't have to go through all of them, but just for you to see that these are the outlines to look at the various, funding landscape globally and in Nigeria. So next slide, please. Okay, we have over 100 attendees. That's very good. And I'm sure you are following what is happening globally, what is going on, in many countries regarding some, tough decisions regarding foreign investment and foreign aid. We're aware the executive order from the USA announcing intention to withdraw the United States from WHO, which will further affect the capacity of WHO to deliver on its mandate. And you're also aware that this mandate of WHO also cover health system strengthening in Nigeria and everywhere to strengthen immunization and primary health care. We are also aware of the stop work order, by USAID across many African countries, including Nigeria, to which halt medicine supplies and staff support, as well as other basic life-saving health needs that provide prenatal, safe childbirth, including vaccines to over 90 million women and children. And also, if you are also following the trend, just yesterday, the United Kingdom Prime Minister, Mrs. Starmer, has also engaged media yesterday to talk about the shifting of some funding. He announced that the UK government is going to cut foreign aid, not everything, but will cut foreign aid to invest more in internal defense and security. This is part of the global health funding landscape. And this message just came yesterday, from the UK. Next slide, please. So we have some example of also global funding shortfalls. We're aware that Gavi will be organizing a pledges summit in 2025 in Brussels early this year to raise $9 billion over the next strategic period, 2026 to 2030. And also the Global Fund is also seeking to raise $18 billion and to also support health funding, health system strengthening. And one of the messages that came out from that announcement is that they will also rely on the UK and other programs to support HIV, TB, malaria, and health system strengthening. This message came before the yesterday announcement of the Mr. Starmer, the UK Prime Minister, announcing cutting foreign aid to invest more on defense and security. We also heard from the EU funding gap, which also mentioned that it cannot fill in the USAID funding cuts, especially in Africa. And they have to also raise a lot of funding to really see how some of these challenges that arises from the USAID funding cut. Now, UK announcement is going to affect the overall foreign aid coming to Africa, coming to Nigeria, to strengthen health system, to promote immunization, and to also address zero-dose children. Next slide, please. So I would like to comment also with the message from our coordinating minister in light of the global foreign funding landscape. The minister mentioned that the 28,000 health workers formerly paid by USAID need to be absorbed by the Nigerian government to continue to pay the salary, other benefits, and ensure that they remain within the primary health care, within the immunization space. I want to mention to the esteemed audience, this is not going to be easy to absorb the 28,000 health workers because Nigeria is also struggling with also delay in the releases of budget. So we need to figure out collectively how these 28,000 health workers that have been paid formally by USAID will be absorbed by the Nigerian government. He also mentioned in one of the press conference that Nigeria need to also leverage domestic resources to strengthen health system in anticipating a decline in the global financing aid. So this decline, like I say, is not only USA. The UK has made an announcement. The Dutch government also last week has announced that they need to also reorganize their own foreign development work. The Canadian, one of the Canadian candidates contesting for the presidency also observed that if he is given chance and he wins the election, he's also going to look at the foreign aid. So you can see challenges are coming, from everywhere. And as a country, Nigeria, we need to also plan so that the immunization, the gains of the past will be sustained and we'll be able to eliminate all the zero dose, those children that are not immunized to ensure that they are also fully immunized. Next slide, please. So I want to begin to look at the options, for us as a country and also as advocates and also as Zero Dose Learning Project, a consortium of FENET and the Africa Health Project Network. We are aware of the current taxation going on. This is an opportunity for raising more domestic resources for health and for immunization. The current Nigeria taxation reform, if carefully harnessed, will provide co-financing for vaccine and immunization. Also, some existing projects can be repurposed in Nigeria to provide additional co-financing. For example, from the World Bank Hub project, from BMGF support to the federal ministry, and also the MOU support that we normally enjoy between BMGF, ADF, Gavi, and the Nigeria Governors Forum, including funding from the European Union and the FCDO. And also we need to work very hard with the state governments allocating co-financing for immunization in the state-approved budget, annual budget, and also to ensure timely release and utilization. We need to work very hard, not only to get approval from an annual budget, but to ensure timely release of that money to improve immunization and also address zero-dose children. Next slide, please. So I want to give you an example of the Nigeria vaccine procurement financing, which is going to prepare our mind that advocacy needs to be at the center of our conversation regarding immunization financing. Please, can we see the table so I can quickly also explain the table for the audience to understand. So I'm not going to discuss all the beautiful pictures on this table, but I want to show you the area, the progression between 2021 to 2026. That is the immunization and the vaccine financing as a co-financing between Gavi and the Nigerian government, and also to some extent contribution from the World Bank. If you look at 2021 to 2026, the contribution of Gavi is reducing while the expected contribution of the Nigerian government is increasing. That is part of the MOU for the co-financing. And Nigeria transition out from the co-financing from Gavi regarding vaccine procurement. Nigerian government need to put more money on the table while the Gavi is reducing money. If we take example of 2024, we have a pie of $335 million for co-financing of all our vaccine requirement, and the Gavi is contributing $160 million, while the Nigerian government is expected to contribute 175 million naira. By November last year, we are still struggling to ensure that 50% of the money from Nigerian government was actually released. That is by November last year, when the expanded ICC meeting took place at the Transcorp during the joint annual review for the sector-wide approach. The 2025 has more challenges. Nigeria is expected to commit $270 million, total of 64%, while the Gavi is expected to contribute about $153 million, roughly about 35-36%. That means more work needs to be done for the co-financing. Side by side with the international changing, funding landscape, and with challenges of dwindling resources in Nigeria, Nigeria expected to commit more money. So that is the challenge. Yeah, we need to put more money on the table, and we have a lot of challenges, from the global space. Then the domestic resources is also dwindling. That means more advocacy needs to be done to ensure Nigerian government commit money, release money on time, and ensure the co-financing to UNICEF to procure more vaccine. So this is a challenge that we need to see, clearly, looking at us, in the face, and something needs to be done to engage our government meaningfully to ensure that our children are fully immunized, and we try to reduce zero dose to the barest minimum if we cannot eliminate the entire zero dose. Next slide, please. We are aware that Nigeria has about 2.1 billion zero-dose children, highlighting the urgent need for sustainable immunization financing. And some of the states that are having one of the highest number of zero-dose, actually within the zero-dose learning hub project, Kano and Sokoto were reported to actually have one of the highest number of zero-dose children. It means we have to do more work to empower our state governments to commit resources to promote accountability and transparency and ensure that the zero-dose children have reduced to the barest minimum. We need to ensure innovative strategies and resource mobilization are crucial to reach these vulnerable populations and ensure they receive life-saving vaccine. Next slide, please. So what are some suggestions I would like to bring from the advocacy point of view? As you are aware, the Zero Dose Learning Hub project, one of the pillars is advocacy, which is being led by AHBN, while the remaining pillars are led by AFENET, but it's done collaboratively. We need to engage strategically with the Nigeria Budget Office, DG, the Minister of Budget and Planning, as well as the Minister of Finance, to ensure that they prioritize domestic resource mobilization in the midst of the dwindling global financial resources coming to Nigeria. With all the challenges I've highlighted earlier, our government needs to prioritize, funding health and also funding the co-financing for Gavi and for immunization. We also need to discuss with the Nigeria Governors Forum and all the 36 states governors in Nigeria to begin to engage on robust state allocation to health and also to immunization. The governors to commit to pay their own 25% anti funding for the basic healthcare provision fund. The governors need to commit to also put co-financing for immunization logistics, delivery from the state level store, local government store, also to ensure cold chain maintenance and infrastructural development at the facility. So while we are getting the vaccine from the federal government, the governors need to commit money to ensure logistics for delivery and also for implementation. One of the also area we need to also engage, which we have not been doing, is to engage the National Security Advisor Office of Nigeria to ensure that the health is among and also is added among the national security agenda. Immunization is a way to strengthen health security, and we need to open the conversation to move outside our comfort zone of the health sector and engage the National Security Advisor Office so that they begin to prioritize health. When they are committing more funding for security, they also put more funding for health security and also more funding for immunization co-financing, both at the vaccine procurement and also at the vaccine delivery. Next slide, please. So this is just a picture of our high-level advocacy in Bauchi and Sokoto states, where we engage His Excellencies, the deputy governors of Bauchi and Sokoto, and our message across everywhere was the same. Commit to finance immunization, commit to accountability, commit to transparency, work as a team, and lead the process, and the government to be on the driver's seat while the partners are also engaging them meaningfully. That's where our messages in these photos while we're engaging the deputy governors of Bauchi and Sokoto State. Next slide, please. So thank you very much, and I look forward to engage with some attendees. If we have questions, even after the webinar, we are happy to engage through the Senate collaboration. This is a very important topic, and now that Mr. President is about to sign the 2025 budget, this is the right time to talk about sustainable immunization financing. Thank you very much, Margaret, and over. Thank you.
Thank you very much, Dr. Magashi, for those insights. Yes, engaging high-level stakeholders and strategic advocacy and collaboration is essential. I agree with you. Thank you very much once again. Next, we have our second session titled Gender Perspective to Reaching Zero-Dose Children in Nigeria. This session will be presented by Dr. Talatu Buba Bello, a gender and development specialist at AFINET. She has led and supported numerous research initiatives focused on gender and health, women's economic empowerment, human rights, conflict, forced migration, and social protection. Dr. Bello has worked with several government agencies, academic institutions, and consulted for local and international organizations. Dr. Talatu, the floor is yours.
Okay, so thank you, Margaret. Good afternoon from Nigeria. My name is Talatu Buba Bello. Today I'll be talking on gender perspective to reaching zero-dose children in Nigeria. So, so sorry for the break. I'll be talking on gender perspective to reaching zero-dose children in Nigeria. Immunization is an important public health intervention that has prevented and is still preventing vaccines-preventable diseases. Immunization coverage differs across settings, and Nigeria is one of those countries battling with the problem of no immunization coverage. Some of the factors that account for this include poor infrastructure, weak healthcare systems.
Dr. Talatu, we cannot see your presentation. Would you like us to present? Dr. Talatu, can you hear me? Would you like us to
I can
share
hear
your
you, Margaret.
Would you like us to share your slides?
Yeah, I'm making effort here to get it right, please. Just give me a little time.
Sure.
Can you see my screen?
It's coming up. Yes, we can. Please go ahead.
Yeah. Okay, so thank you. So the topic once again is gender perspective to reaching zero-dose children in Nigeria. And immunization is an important public health intervention. It has prevented and is still preventing vaccines-preventable diseases. And the immunization coverage differs across settings, and Nigeria is one of those countries battling with low immunization coverage. Some of the factors that account for this include poor infrastructure, weak healthcare system, poverty and insecurity, socio-cultural belief system, and entrenched gender inequality. Suffice it to know that Nigeria's low ranking in the Global Gender Equality Index arguably has impacted and causing a low performance in its terms of immunization. Currently, Nigeria is housing 2.1 million of children that have never received Penta-1 and are known as zero-dose children. To reduce the number of zero-dose children, the National Primary Healthcare Development Agency, in line with Immunization Agenda 2030 and Gavi 5.0, has articulated and rolled out strategies, including a CBROAD plan, the Big Catch-up, and the ITV, aimed at reducing the number of zero-dose children in Nigeria. The Zero-Dose Learning Hub in Nigeria is using gender lens to uncover barriers and facilitators to uptake of routine immunization. And the aim here is to generate evidence to support the government to make informed decisions on how to reduce the number of zero-dose children in Nigeria. Before I continue, I will take time to explain the concept of gender and how it plays out. Gender is a social construct. It helps or it shapes division of labor at the home front between males and females. It also shapes standard of behavior for males and females. It determines the level of access to and control of resources between males and females, including opportunities. Gender is specific and gender changes over time. Sometimes the word gender is being used in place of sex. However, these two have different meaning. Sex is a biological construct. It is universal and it's unchanging, even though we know that some people don't share this binary notion. However, this is not the focus of my current presentation. I also want to take time to explain some practical ways in which gender play out and how it shapes inequality, leading to barriers to uptake of routine immunization. As important as driving a car is, we all know that in some settings, it is only recently that women are given a right to drive a car. In northern Nigeria, voting started for women. Voting in an election started for women in 1970s. Meanwhile, in southern parts of Nigeria, women started voting as far back as 1950s. Their male counterparts across the country started voting long before the women started voting in Nigeria. We all know that in some parts of northern Nigeria, girl child education is not prioritized as they are married out early in life, while the male children are allowed to go to school to get educated and get empowerment. We know that climate is fast changing, and because of unequal division of power at the home fronts, it is the women that need to travel far distance to fetch water and firewood to come and help their family home. A woman recently said that her grandmother told her that it is cultural to bring her money, any money at the end of the month for her husband to bless it so that she can be able to assume the position of good wife. A local newspaper recently reported in Nigeria that a woman sustained broken hands and legs from beating she received from her husband simply because she went to health facility to access care for herself. We can continue to give you on and on different areas in which gender play out and is causing inequality between males and females, which in turn cause barriers in their attempts to access RI for their children. Accumulation of these differences, the accumulation of these inequality and these differences, especially put women in a marginalized position with weak capacity to provide help for themselves and their children. This is the focus, and this is key. And for every public health intervention that is trying to uncover barriers to access to health services, this should be the focus. And when we talk about gender in immunization, that is exactly what we mean. Sometimes people think that just representing the number of males and females in the program, it means you're mainstreaming gender. No. Mainstreaming gender involves unraveling or unbundling the gender inequality that exists between males and females. And it is only that way that we can be able to understand what barriers exist for what category of people in their attempt to access different health services, including immunization in Nigeria. We all know that in Nigeria, or across the world, the caregiving role is specific for women. So, but then because of gender inequality between males and females playing out at different levels, at the health fronts, at the community level, at the health facility, is undermine the capacity of health of caregivers to effectively provide care for themselves as well as their children. So, applying gender lens is crucial in understanding the different forms of barriers that exist for women at different levels. So, why are we talking about gender in routine immunization? This is because there are barriers that are impeding against caregivers' ability to access care, and including routine immunization for their children. And from literature, we have problem of lack of decision making. Women are the caregivers, but they don't have the power to make certain decisions on important issues, including take of health services for their children. So this is a problem, and it can impede against ability to vaccinate and serving as a barrier. The next thing is poverty of time, and this is linked to unequal division of labor at the home front, women working in professional roles and juggling with household duties, it leads to trade-off, and then the child vaccination suffers. Another problem on the side of the demand side includes low level of education of women. Women, most especially in rural communities, lack the education, so they don't even understand the importance of immunization for their children, and they find it difficult to navigate their way, even at the household level, to be able to vaccinate their children. And when they go to health facility, because of lack of information, lack of education, it can also make them behave well. And then person problem and lack of understanding between them and the healthcare workers that may lead to them embarrassing them, and they may not want to come back to the health facility to access care. Another problem is lack of financial capacity. Because of weak status of women, they lack access to finances. And sometimes even access to household resources they cannot be able to use to facilitate public immunization. In Nigeria, we know that immunization is free. There are indirect charges attached to accessing routine immunization, such as cost of transportation or to buy a kind of a supply to relieve EFI in case it occurs after vaccination. And on the part of the supply side, there are issues around poor attitude of healthcare workers through uneducated caregivers. The health facility emphasis on women alone attending RI sessions, meanwhile the male counterpart can equally participate to support in vaccinating a child. Another problem is lack of inclusion of women in RI planning, and then limited number of women and mobilizers at the community level. In northern Nigeria especially, there are places where males are not allowed to enter into household to interact with caregivers. So limited number of women can also serve as a barrier. So having known the importance of gender in immunization, so let us take time to explain some key steps involved in doing a gender-sensitive RI programming. First, we need to understand we need to generate evidence, and how do we generate evidence? It is through research. So research in terms of understanding barriers and the uptake of immunization is key, and this should be done across all levels of the project cycle. The time of developing a research intervention proposal, programmers need to understand that they need to be intentional to mainstream gender in a way that it will make funding available for the implementation of these activities going forward. The next step is to design a gender-sensitive, responsive, and transformative strategies. Gender-responsive strategies include all those activities we can do to support us in vaccinating children on the go. In Nigeria, there are practices of incentivizing routine immunization. This is when caregivers are given stipends at a health facility after vaccinating their children to enable them return to the health facility for take of more doses. And then we also have engagement of male head of households in order not only to give permission to their wives to vaccinate their children, but also to support other head of households to do the same. But I would like to say that these strategies are not transformative. They are only responsive. Yes, they help in reducing the number of zero-dose children by vaccinating them, but it does not transform the equal power relations between males and females that form the basis for inequality, that forms barriers for caregivers. So while we do these responsive strategies that help us to vaccinate children on the go, we also need to put a plan to make effort to transform the relationship that in a way that empowers the caregiver to take the decision to vaccinate their children on their own. And ask ourselves and say, what if the funding stops? What if the male head of households refuse to give permission? Or what if they are not around? Then the caregivers are left without an option than to decline from accepting or vaccinating their children. So there is need to be transformative in approach in a way that empowers the caregivers to vaccinate their children on their own. The next key
Dr. Salatu, can you hear us? It seems we lost you. Dr. Salatu, I can see that you're still logged in. That's just a brief break in transmission. We'll have her join us very shortly. Yes, I see her rejoining. Apologies for that. Dr. Salatu, if you can hear me, you could take over the sights and sounds and continue. Yes, there you are. Go ahead, please.
Hello, Margaret. Can you hear me?
Yes, we can. Please go ahead, Ma. Thank you.
Okay, so thank you. Sorry for the break. I would like to continue from where I stopped. So we noticed that the healthcare workers lack the basic capacity to implement gender-sensitive activities. So there is need to build their capacity in order to be able to implement these gender-sensitive activities. Again, there is need to design gender-sensitive indicators, track these indicators and measure and monitor them, and also document them for learning. I would like to take some time to explain some of the activities the Zero Dose Learning Hub is doing in order to support the government in their effort to reducing the number of zero dose children in Nigeria. We are not directly vaccinating children, but we are generating evidence that guides decision making. And one of these evidence we have generated recently is the conduct of implementation research in Sokoto and Bauchi states, and we have generated key findings, which I would like to take time to explain as we continue. So we also use evidence to conduct advocacy that enhance better outcome. You heard from the previous speaker what we are doing around budget tracking, budget release, and so on and so forth. So these are part of the things we do. The next thing we do is we identify capacity gaps among healthcare workers in relation to integrating gender in routine immunization, and we build their capacity. And one of those things we recently did is around the fellowship we are currently doing in that brings together healthcare workers, including monitoring and evaluation officers across the 4 learning states. And then we mainstream gender into the curriculum, and we build their capacity on how to design gender-sensitive indicators and how to track it and measure, and then documents. So I would like to take some time to explain some of the evidence we've generated from Sokoto and Bauchi states. One of the key factors or barriers preventing caregivers from vaccinating their children is weak agency. And what I mean by weak agency is lack of decision-making power. Across the study area, 93% of the sample respondents have indicated that they need spousal permission to vaccinate their children. And in a situation where this permission is not there, they are left with no option than not to vaccinate their children. Another problem linked to the weak agency of women is lack of formal education. Only 25% of the sample respondents across the study location had access to formal education. So they are left in a position not to even understand the importance of routine immunization for children, and they're not being able to negotiate their way to be able to get some certain services, including routine immunization for children. Another major problem still linked to weak agency of women is lack of income and the lack of control over finances. Only 14% of caregivers had access to and control of family resources to facilitate child uptake of routine immunization. So this is a barrier, and altogether it leads to weakening of the capacity of women to take decisions and vaccinate their children. Another major problem we have discovered around at the level of the community is patriarchal communal norms. There is a culture of silence over male dominance in decision-making at all, in all matters, including health of the family and then of the children. So women in the community, even if they know the importance of vaccines for their children, they don't know they don't know what to do, because even the culture itself is telling them that, look, their husbands is leading in everything, including decision-making. So the gatekeepers cannot do anything, religious leaders cannot do anything. This is left in the discretion of the head of households to decide to allow the wives to vaccinate children or not to. So this is a barrier stemming from the community level. Again, another barrier is that there is restriction on women travel autonomy. From most of our findings in our learning hub, there are women living even within 2 kilometers to health facility, and yet they don't go to the health facility to accept RI. This is simply because most of them are living under cultural practices such as Buddha, where they are not allowed to go out, except maybe sometimes with a male figure, and then, or maybe they are only allowed to go out in the night. So all this boils down to cultural practices, and it's impede against caregivers' ability to vaccinate their children. From the side of the supply side, we understand that there is gender-blind RI system and policies. Suffice it to know that Nigeria has a national gender policy on health and the national gender policy overall, but then across the expanded program on immunization, there was little evidence of mainstreaming gender. So what we advocate here is that review these policies or strengthen these policies in a way that it will clearly explain or stipulate how gender is should be mainstream, and it should be prioritized across immunization space. And there is also the problem of lack of gender-sensitive RI data platforms, the National Health Information Management System, and then the DHS IS2. These are the major platforms where data is derived for decision making. But suffice it to know that these platforms don't take gender disaggregated data or sex disaggregated data, as currently we don't know if we're vaccinating more male children than female children or not. We don't know because these data, RI data platforms is not telling us anything about that. It's additionally, again, the social characteristic that determine uptake of routine immunization is not captured here. So what we are advocating is the review of these data platforms in a way that captures this important gender-sensitive information so that it supports government to make comprehensive, inclusive decision-making around routine immunization. So from us here in the Learning Hub in Nigeria, we have itemized some three key important activities to do that we believe will help reduce barriers and then increase uptake of routine immunization, and in turn, reduce the number of zero-dose children. So currently, there is need to advocate for inclusion or empowerment of women. And I would like to say, with a heart full of joy, that Nigerian government, through the Ministry of Women Affairs, currently has a plan to empower 10 million Nigerian women across the 36 states, including FCT. So this is a window of opportunity for us to advocate for the inclusion of caregivers of children that are not vaccinated, or the zero-dose children. So assuming we're able to advocate for the inclusion or enlisting of these women, so at the end of 2027, we should be able to have 2 million women economically empowered, which I believe will strengthen their capacity to accept routine immunization for their children. Another thing we want to do in the direction of advocacy is to be able to mainstream gender and good behavioral, health-seeking behavior into the modules used to train these women. So these women at the end of 2027 will not only come out being empowered, they are conscientized and sensitized about the importance of taking vaccination for their children. Also, in terms of advocacy, we intend to advocate for the review of the National Health Information Management System and the DHS IS2 to include sex-disaggregated data and social characteristics that determine health status. And then lastly, we're advocating for the review of the Rio Macro Plan and Session Plan. So during our study in Sokoto and Bauchi states, we realized that important places like safe spaces, shelter, communities of people living with disabilities, sex centers, sexual assault referral center, harboring women and children are not, there is no any link between them and health facilities to vaccinate eligible children. So this is a finding that we want to advocate for review of this macro plan in a way that it captures this collection of people in a way that will enable us to link these children and then vaccinate them. So that way it will be able to reduce the barriers and then increase the uptake and reduce the number of zero-dose children in Nigeria. By way of conclusion, gender barrier prevents equal access to routine immunization services, and integrating gender into policies, frameworks, and the design and implementation of routine immunization is key. And investing in education and economic empowerment of caregivers can help reduce inequality and increase coverage in Nigeria.
Thank you, and over to you.
Thank you, Dr. Bello, for that insightful presentation. It is definitely clear that gender perspective plays a crucial role in our efforts to reach zero-dose children, and we appreciate your valuable takeaways shared. I'd like to open the floor now for a discussion session, an experience sharing session. So this is a great chance for you to ask your questions, share your insights, your own experience from the field as it pertains to the presentations taken today. So feel free to raise your virtual hand or use the Q&A box to join the conversation. We have some questions here already. Our speakers have done well to respond to some of them. However, we request that you keep your contributions brief due to time constraints. Longer comments may need to be cut short. We thank you for your understanding. So let's dive right in to see who is asking questions. Okay. Oh, I see Dr. Muhammad Bashar Jibril. Please unmute yourself, sir. You are very welcome. Dr. Jibril, I'm aware, works with the National Health Insurance Agency. He provides technical support, or rather he provided technical support formerly and currently as well to the Director General. You're welcome, sir. Please, your comment and your contribution.
Thank you very much for the presenters, for the insightful discussion. For Dr. Magashi, I was happy with the actionable recommendations, but as low-hanging fruits, I would like to suggest the possibility of increasing the basic healthcare provision fund from 1% of the consolidated revenue fund to 2% to increase domestic funding. Another low-hanging fruit we can capitalize on is part of the proceeds of the VAT value-added tax can be earmarked for routine immunization services and activities in the country. Then of recent, there is the passage of the sugar sweetened beverage tax, which was introduced. I don't know what is the current situation with that tax, and if we can leverage that SSB for funding routine immunization services and other healthcare delivery services. Vulnerable Group Fund, which was also established by the NHIA Act 2022, can also be leveraged so that we can expand our domestic financing. I'm happy that part of the beneficiaries are marked under the Vulnerable Group Fund are children under 5. Can that be advocated for government to populate that, and part of the proceeds of the Vulnerable Group Fund can be used for routine immunization? So also the recently introduced financing access to comprehensive emergency obstetric care by the National Health Insurance Authority. Can part of it also go to fund routine immunization, especially now that we are talking about international changing funding landscape? So these are some of the low-hanging fruits I want to suggest. And I also advise if we can advocate for that to expand domestic funding for healthcare. For Talatu, I'm also happy with some of the recommendations. Also, as low-hanging fruits, can we look at the possibility of training routine immunization as well as M&E staff on gender mainstreaming? Because most at times we are restricting our training to monitoring evaluation. How can we mainstream gender mainstreaming into their trainings? So also ensuring we make available gender disaggregated data. So also focusing on M&E for measuring progress. We look at what extent the gender focused M&E can be introduced so that we can see what progress we are making, especially with the alarming information we just received that we don't even know how many girls and boys are being vaccinated. So I believe this is a low-hanging fruit if we want to mainstream gender issues into our routine immunization services. Involvement of stakeholders. You have mentioned so many issues across the family, the household, even the community. Can we look at the possibility of involving stakeholders across all levels to see how this will support us in mainstreaming gender issues into our own activities? Thank you very much for your time and for your patience. And congratulations.
Thank you, Dr. Sorry about that. Thank you very much, Dr. Jibril. To the speakers, please take note of the questions that are coming up. We'll take a couple before we go ahead. I have Adamu Yusuf. Please unmute yourself and ask your question or make your contribution. Adamu Yusuf.
Okay, good afternoon. Sorry, this is Stephanie joining with Adamu Yusuf's link. I have a question. Thank you so much for the wonderful presentation from both presenters, so insightful. And my question is, what specific strategies have Afinet implemented or advocated for so as to engage women as primary service providers in vaccination activities? And how effective have these strategies been in reducing the number of zero-dose children? Sorry, am I clear?
Yes, you are. Thank you very much for your question. The speakers have that noted. Salisu Baba, please unmute yourself and ask your question or make your contribution. Salisu Baba.
Thank you very much for the previous speakers, that is Dr. Amin Mazeshi and Dr. Malatu. I'm Salisu Baba from Chigere Foundation, and I'm happy to share with the team that since 2016, the current coordinating minister of health, Professor Ali Fati, has initiated the idea of sustainability and ownership of PSC services, which include the RI program. And he initiated the Chigere Foundation as an NGO supported by BMJ and Algati for promoting sustainability and ownership. And since that time, almost 9 years, they are doing a lot, but mainly on the MOU states. That's the 7th state, which is funded by BMJ and Algati. So my request or advice or input is for especially Dr. Aminu Mageshi to make sure that they link up with that issue of sustainability and ownership, because there is current community engagement strategy that was developed during the 2016 to 2017 on how to promote sustainability and ownership of primary healthcare services, particularly the RI, so that the community will own some part of it, including the financing, including particularly the creating demand. So looking at the role that traditional institution has played during the elimination of polio, I think the RI and other PHC services with this critical issue of financing landscaping that is happening globally can be strengthened so that the system can be utilized, work with traditional institutions to build more hospital by the community, to fund some of the areas, particularly the vaccine supply chain and other things. I'm sure our community, our traditional institutions are up to the task to do that. Thank you very much. Over.
Thank you, sir, for your contribution. And I have a question here from the Q&A box. It's from Nanret Yakubu. Nanret Yakubu, and the question is to Dr. Magashi. He says, thank you for the insightful presentation, sir. Please, is there any modality that supports or is planning to support local vaccine production in Nigeria? Dr. Magashi, I hope you got that question. Is there any modality that supports or is planning to support local vaccine production in Nigeria? And a question for Dr. Bello. It says, how do we resolve the issues of social barrier or fear or stigma, which is hindering adolescent girls and women of childbearing age who are not married from going to the health facilities for the TD vaccine? I'll take that again. How do we resolve the issues of social barrier or fear of stigma, which is hindering adolescent girls and women of childbearing age who are not married from going to the health facilities for the TD vaccine? I will open it up for the speakers now to take it, starting with Dr. Magashi, not being gender biased. Dr. Magashi, please, the floor is yours. Kindly put your video on as you speak. Thank you.
Okay. Thank you very much for this question regarding the local vaccine production. Also, let me appreciate our leaders from NHIA who talk excellently about funding options, for the financing immunization, and also our colleague from Chigari Foundation. I'm sure our team from Bauchi, Kano, Borno, and Sokoto should take advantage of Chigari Foundation operating in those states, plus the additional 3 states. And I saw them, many of them are online. Please jot down that we need to engage Chigari Foundation to understand the concept of the ownership of the primary healthcare, how to promote sustainability, and we can now expand our advocacy from that regard. The NHIA recommendation to expand the basic healthcare population fund from 1% to 2%, that's an excellent and brilliant idea. There's already an ongoing discussion to go back to the National Assembly to amend the National Health Act to make it 2% from the 1%. But we need to also do more to ensure that the 1% is also coming out on time and also coming out as 100%. In 2025, the Nigerian government has approved over 500 billion naira, for the 1% of the BACPF. And in 2024, we have over 250 billion naira. In 2024, the coordinating minister was still working hard to pay all the backlog of 2023, also to start paying the 2024. In 2025, we need to pay some money from 2024. I will also need to mobilize and spend another 500 billion naira. A lot of work needs to be done. If we are moving to 2%, we need to spend the 1%, then we also engage in the 2%, which I also agree. We should start having that conversation with the National Assembly. For the Vulnerable Health Fund from NHIA and the financing the emergency obstetric services, will come to you so that we can also engage the NHIA DG to start having an honest conversation on how to co-finance our immunization. You also mentioned the sweetened sugar tax. The money is entering into a bigger pool, not the health sector budget. We should do more to also earmark that sugar tax to the health sector. The value-added tax is part of the reform agenda of the tax reform. We should also engage the Minister of Finance and the DG budget also in that area to ensure that health sector has gotten some money from the taxation reform and also from the value-added tax. The last question, just quickly, I know I don't have too much time. The local vaccine production is also a viable tool to improve our immunization. You are aware that the third pillar of the Nigeria health sector investment, the health sector reform and investment initiative, the third pillar of that reform agenda is unlocking the health sector value chain. And based on that, a presidential initiative was established to unlock the value chain. Through that, we should engage qualified industries developing drugs and vaccine to start having that discussion through the initiative on how potentially Nigeria could begin to explore local vaccine production, engaging Gavi, engaging Africa Development Bank, engaging the Africa Export and Import Bank, and all the critical players in Africa to ensure that Nigeria has joined the League of African countries to develop local vaccine production. Thank you very much, and I can still come back if I have additional time. Thank you, moderator. Over to you.
Most definitely, Dr. Magashi. Thank you very much. Dr. Talatu, your responses, please.
Yeah, so I would like to respond to a question around the strategies, effective strategies for women involvement in routine immunization activities. Well, I would like to say that across the study location where we have worked, we discovered that there is a lot of cultural practices that restrict women from doing so many things. So you don't just go like that and begin to call the women to gather in a place and you begin to educate them and let them see the importance of what you want them to do. So what we are recommending is that we use leverage existing women groups and then key influencers, even especially among women, and then including male engagement and then gatekeepers all together will to create a kind of understanding among them so that they don't see women gathering or women going out to do some things and then they begin to be offended and causing problem in the community. So engagement of these key influencers and these key people at the community level will have a way of improving women participation in public activities, including going to the health facility to access some certain services. And again, a question around how do we reduce stigma among young adolescent girls? Well, one way we can do that is to engage in robust behavior change communication and then involve in the activities around reducing gender-based violence, because the stigma against these young girls is gender-based violence. Why gender-based violence occurs sometimes is because the people perpetrating this gender-based violence don't even know. So when we create around awareness around stigmatizing women, especially young girls, by trying to reduce gender-based violence, it will have a way of reducing the stigma against these young women. Thank you. And over to you.
Thank you, Dr. Talatu, for those responses. And we go ahead with another session of questions. A very interesting question here. It says, with the withdrawal of international funding, what strategies can Nigeria adopt to ensure that immunization programs remain uninterrupted, especially in rural and mixed communities? That's for Dr. Aminu. Another question for you is, in the advent of withdrawal of funding by USA and UK, I think it's a similar question, what mechanisms can you put in place to ensure prompt and timely release of funds so as to augment health financing, so as to ensure symmetry in immunization supplies in our African countries? For Dr. Buba, I have a contribution from Ibrahim Muhammad Bande. He says, I would like to highlight a promising initiative in Yobe State, where community resource groups engaged in demand creation and linking caregivers to facilities have transitioned to being female-led. This strategic shift has optimized performance at the community level. To further amplify impact, I recommend scaling up this gender lens approach across all levels. By doing so, we can, number one, enhance program effectiveness, two, ensure more accurate data documentation, and three, foster a more inclusive and equitable environment. By adopting this approach, we can unlock greater potential for improved health outcomes, particularly in underserved communities. That was a contribution. A question is, I am a health worker. One of the problems we face is that women always come late to health facilities for routine immunization. What should we do? And somebody says, thank you, Dr. Talatu. I need a little elaboration on how to generate evidence through research in gender-sensitive approach, and should it be driven by male or female actors? That's the next set of questions I'd like you to take. But a quick request to the speakers, to the presenters, please respond to the questions in the Q&A box, because we may not be able to take all the questions right here as we are speaking. So please go into the Q&A box and type in your responses to the attendees. I'll start with Dr. Buba this time. Dr. Talatu, please go ahead with your responses to the questions and contributions. Thank you.
Okay, so thank you very much for that question. On the issue of women going late to health facility, first of all, as people working within the immunization space, we need to find out and get to understand what are the reasons why women go late to health facility to vaccinate their children. And what we need to do is to engage the women and get to understand why the reason. So most of the times we find out that it's either they go during the day or in the morning, and then they go to the markets to transact their businesses, then that makes them to go late. So the fact that they come late to health facility shows that there is something we are missing. So the design of the RI session itself should have been that help the women tell you the time that they will be able to be around to attend to go to health facility to vaccinate their children. So there is need to go down to the community level, discuss with the women, and let them give the first time they think it will be better for them to come out and vaccinate their children. So this way, I think it will have a way of reducing this late coming to routine immunization. And then again, we can choose to extend the RI section timing. So in a way that at any time a caregiver gets to the facility, she should be able to vaccinate her child. Thank you. And then again, there is a question around should immunization activities be driven by male or female? My question is that it should be driven by all, because all of male and female are equal participants, they're equal players, so both of them should be involved in order to drive immunization activities. Thank you, and over.
Thank you, Dr. Talatu. Dr. Aminu, your responses, please.
Okay, thank you very much also for these two questions. They are all related to the global direction and funding challenges. So just to clarify that the USA and the UK and all the bilateral development and donor partners, they are not cutting funding at 100%. Some are kind of suspending or reducing. So we're not we haven't heard from anywhere where they are stopping everything at 100%. Some there's a cut. Like what the announcement by the UK Prime Minister yesterday was that they will cut the foreign aid to finance more of defense and security. The US, they suspended. That's a stop work order. So we hope that gradually this may be resolved. But as our coordinating minister said, that we need to anticipate this global dynamics and the global change. And also the global community are also, by doing this, calling African countries, including Nigeria, for accountability and transparency on all foreign support coming into our country. So indirectly, that's what also they are calling for. The funding we are giving you, it should also be accountable and transparent to deliver to the ordinary Nigerians and also ordinary Africans. So the best way to go about it is to tighten our belt to be more efficient, more transparent, and more accountable to available resources locally and coming from the foreign aid. I want to give you an example. 2025, there's over 1 trillion naira for health sector budget alone, approved by Mr. President and the National Assembly. That, to say, could be the highest over the last 10 years in terms of numerical value. Even with the value based on the exchange rate, it is still a huge amount of money. And also the Basic Healthcare Provision Fund that my senior colleague from NHI mentioned has about 580 billion naira in the 2025 approved budget. We have also immunization co-financing, about money over 200 billion naira, money for counterpart funding, for global fund, for essential service. It means that the domestic resources are already available. What we need to do is to scale up our game of advocacy and mutual accountability between the government, the CSOs, and the governors forum, and also the governors of Nigeria, so that they begin to invest in health. And I mentioned the Office of the National Security Advisor need to prioritize health as a national security agenda, so that more funding can be pushed into health, and we can reorganize our health security agenda to also promote immunization that protects our children and women to improve their own positive health outcome, and also address the critical need of our human capital development. A lot needs to be done, and we look forward to more engagement after the webinar. Thank you very much, and over.
Thank you, Dr. Magashi, for those responses. I'd request you to please type responses to the open questions in the Q&A box. And while you're doing that, I'll bring out some more questions. I also see a hand up here. I see Tabitha Ngyal. I'm sorry for I mispronounced your name. Tabitha Ngyal, please unmute yourself and ask your question or make your contribution.
Good afternoon.
Good afternoon, you're welcome.
Okay, so my question is to Dr. Talatu Buba. How can community-based initiatives like women groups or community health workers be leveraged to promote vaccination? Am I clear?
Yes, you are. Yes, you are. We got that. Thank you very much. Yes, thank you. The next question I have for Dr. Talatu is, one of the challenges we are facing when we go for outreaches is that women don't like to come out themselves to the RI collection point. Rather, they send their older children with the child for vaccination. How do we communicate important RI information to caregivers? I think this is a very important question. Another question says, for lack of money and lack of awareness, the women in my community rely on herbs to treat their children. What to do so they visit the health facility rather than do so? And what do we do as health workers? I hope you got those questions. Dr. Magashi, a question here is, partners in Nigerian health system have tremendously contributed in reshaping Nigerian health system, especially in immunization budget allocation, accountability, and transparency. What efforts are partners taking to support Nigeria in creating sustainable financing models and resilient health systems in events of aid diminishing? I'm sure you've touched upon that subject in some way or the other. Another question is, how can advocacy and civil society organizations contribute to ensuring that immunization financing remains a government priority amid shifting political and economic landscapes? Those will be the last set of questions we are asking this afternoon. Please go ahead, Dr. Magashi, with your responses. Dr. Magashi, can you hear me?
Yes, I can hear you now. So,
yes, sir.
As you rightly said, I already touched some of them. And one of the questions that you just highlighted now is the role of the partners, to ensure that the Nigerian government, both at the federal and also at the state and the local governments, are investing more in health and immunization. So, to me, this is one of the ways. This webinar we organized by the Zero Dose Learning Hub Consortium in Nigeria, AFN and AGBN, is one of the ways to raise the bar, for conversation and honest discussion in supporting our government. We are also aware that within this learning hub, the Zero Dose Learning Hub, we have developed a state, budget, immunization, and accountability scorecard that also, report on an annual allocation, releases, and utilization of immunization financing, and also accountability measures to hold government to account to encourage governors to release more money. So these are also ways to support the Nigerian government. We also need to engage at established government mechanisms. So I want to give an example, and I'm sure some advocate will be also gearing up. You are aware that the coordinating minister has strengthened what he calls ministerial oversight committee of the basic healthcare provision fund. This is a quarterly mechanism that brings government, international development partners, donor partners, and the key players in NCDC, MPSCD, and NHIA in the federal ministry to be having a quarterly dialogue on expenditure and utilization of the basic healthcare provision fund. That is a very good strategic mechanism, for us as partners to be engaging to ensure that the gains of the sustainable financing is also affecting possibly all Nigeria. We should also engage, as you're aware, annually the minister organizes the annual Council on Health, which is also the largest congregation of all the commissioners and the minister and the donor partners. These are also mechanisms. Engaging with the National Assembly, the healthcare committees at the Senate, and also the House of Rep to strengthen oversight function by visiting MPSCDA, by visiting the stores, the warehouse that are hosting the vaccine, to ensure the move from federal to state to local government. At the state level, we need to also strengthen the state oversight committees. At the local government through ALGON. We also, now that they have the financial, the financial, immunity and also independence to do more, we should also encourage all local government chairmen to put health on the agenda, of whatever they are doing. The media need to be engaged vigorously and strategically so that they can also be raising the issue of healthcare financing, sustainable immunization, and also placing the health on the agenda. Thank you very much, moderator, and over.
Thank you, Dr. Magashi. Dr. Talatu, your responses, please.
Right.
Okay, so thank you for the questions. I would like to respond to the first question that says how to engage community-based women groups to improve RI uptake. I would like to say that engaging women groups is important. And what we need to do is to map this women group and then be able to pass effective information or communication to this women group to be able to help in driving this behavior change or in driving the very objective we want to achieve. We know that women groups live in the community, they live with the people, they know the people themselves, some part of the people. It's power that women have when they gather together. So when we leverage this kind of platforms, it is good that we are precise and we are intentional about the kind of message, kind of objective we want to achieve. And to say that also, the Liberating Women Group has a way of building the agency of women, because what an individual woman is unable to achieve when they work in group and advocate for certain issues, it is likely to be heard within the community. So this is a very key, important step in order to improve uptake of routine immunization through these platforms. Question that says some settings where women don't like themselves to come out to vaccinate their children during outreaches. Rather, they prefer to send children, especially female children with the child, to bring to the vaccination points. So I would like to say that this is not really too bad, even though we would prefer women to come out to vaccinate their children so that key important health information will be passed to the caregiver. But at the same time, if female children are sent with child to go and vaccinate, it's still not up, because it's an opportunity to build a consciousness of vaccination among these young adolescent girls as they come out to present their young ones for uptake of routine immunization. And we should also emphasize it shouldn't be just the female children. Even the boy child can also be engaged to bring younger ones to vaccination points. So that way, it will put in the child will grow to understand the importance of vaccination, and will support vaccination. Then the last question is around for lack of money, and then lack of awareness. Of course, some people prefer to go for local herbs to address some health issues among their children. But we will know that it's simply because these people don't have awareness, that maybe they don't know the importance of Western medicine or routine immunization. So there is need to create awareness to let the women know that yes, these things are more effective even, and it has been proven to be effective. So create awareness among these women, and also let them know that these vaccine services are not nobody is charging anything. It is free. So if, for instance, they live far away from health facilities, so what is telling us as PRIDE programmers is to design strategies that take these vaccines to the core point of these caregivers. So one think it will have a way of improving the uptake of routine immunization among these people. Thank you very much. Over.
Thank you, Dr. Talatu, for your responses. I hope the speakers are typing in their responses to the questions in the Q&A box, because we have actually come to the end of our discussion session for today. It has been highly engaging. You would agree with me, and we have an outbreak of questions still here. I see Abbas Mohammed from ABAE New Incentives saying, I want to say a big thank you to the presenters for this insightful presentations. Looking forward to more meetings. Most definitely, we will meet you at the next webinar. It's called bi-monthly, by the way. Somebody wants to share a success story. He says, please permit me to share a success story in the Q&A on female gender empowerment on routine immunization at Chilankori settlement of Katagum LGA, Bauchi State. But I don't see your hand up yet, but that's okay. We have with us, as I mentioned before, Reda Sadki, who is the founder of the Geneva Learning Foundation. So would you like to give us a few remarks? We recognize your presence in our midst, and it will be an absolute honor to hear from you. If you can hear me, please raise your hand and unmute yourself, and you could speak, please. While that is in motion, we have heard from both our expert speakers today, from sustainable immunization financing to gender barriers or gender consideration in the immunization space. We have heard it all. And I'd like to call upon none other than Dr. Ndi Waziri to top off the session, the discussion session, with her perspectives. Dr. Waziri is a seasoned public health expert with a proven track record of driving impactful immunization and primary healthcare initiatives in Nigeria and beyond. Dr. Ndi Waziri is the Immunization and Primary Healthcare Advisor at the AFANET Secretariat in Uganda. It's a pleasure to have you with us, Dr. Waziri. Please take it from here.
Yeah, Margaret, thanks so much. I hope you can hear me.
Loud and clear.
Yeah, so I thought I'll be doing the closing remarks, but if you want to hear my perspective, then that's very, very okay. We've heard from Dr. Aminu, we've heard from Dr. Talatu. I think now is the time to put in more money, more funding in immunization systems, because when we talk about prevention, immunization is one of the key tools that we use in prevention, generally in preventive medicine. So issues around sustainable immunization financing in Nigeria, it's very, very vital. It's good to hear that the government of Nigeria, through the minister, is making landslide improvements in immunization system funding. I think I'm glad to hear. I'm happy to have heard that from Dr. Aminu. And really, Dr. Aminu, thanks for sharing your insights. We've had some conversation around how can we get more commitment from the state. And I know you had spoken around reaching out to the governors, doing more advocacy, and trying to see how we can get state to put in more finances in primary healthcare, but also in immunization specifically. In terms of gender, definitely we can't talk about immunization without talking about gender. How can we get, especially our men, to support the women in going for immunization services? Supporting women does not mean providing just the transport for them to go. No, but being part and parcel of our children's immunization. How can we get our spouses, the husbands, our fathers to get their children to be the ones to take the kids to the facility for immunization? How can we get them to be the ones to be to be a reminder system in our communities to drive immunization? I was happy when I heard the question around how can we get use our community structures to strengthen immunization. So at the community level, most of the structures that we have that are functional are male-centric. How can we use those male-centric structures to drive immunization at the community level? How can we get our men to empower the women to seek for healthcare services as at when due for their children? I think those are very, very insightful conversation that we've had. And thank you, Talatu, for sharing your perspective. In terms of the Nigerian landscape, it would be nice. I know we have seen some shift, we've seen some improvement, but it would be good for us to push for more involvement of male in immunization. It's when you go for immunization sessions, it's rare to find the men there. So let's drive the men, our male colleagues. How can we get our male colleagues at the community level to drive immunization? I think the onus is on us to play our own part and ensure that, you know, we run an all-inclusive system that provides for even men to go for immunization. Because a lot of times when you go, they ask, where is the mother and not where is the father? So can we begin to change that narrative so that the men can also feel comfortable when they are in the primary healthcare seeking for immunization services for their children? With that said, I would like to really thank all our participants today. I think at some point in time, we had about 150 participants. I want to thank you for being a great audience. Thank you for all the questions that came in. Thank you for the contributions. I've seen some contributions in the chat. So we really want to thank you for being part of our 6th Zero Dose Learning Hub webinar today. We look forward to having you in our future webinars. Like Margaret said, the webinars are bi-monthly. I'm sure we'll have an interesting session in the 7th webinar. For our presenters today, Dr. Aminu and Dr. Talatu, thanks for sharing your perspective. Thanks for the excellent work that you do. And thanks for opening up to teach us about what you do in general. Thank you, thank you, thank you. Thanks to everyone. Thanks to our moderator, Margaret. Thanks to all the team that have put up this webinar together. Thank you for the excellent work. And we look forward to having every one of you in our next webinar. Thank you very much. And over, Margaret.
Thank you, Dr. Waziri, for your thoughtful and insightful remarks. She's a gender warrior, and she always leaves us with some thought-provoking questions. How do we get our fathers, male colleagues, and generally the men in our lives to take up their responsibilities? It's a very, very crucial question. It's posed also to all the men gathered here. Thank you on behalf of the Zero Dose Learning Hub Nigeria team. We sincerely thank our speakers, Dr. Magashi, Dr. Talatu, for contributing to the success of today's webinar. Your dedication is truly unmatched. Thank you for addressing those Zero Dose challenges and enhancing immunization coverage. It's truly inspiring, all your work so far. We thank you, our repeat and new participants. You're welcome, you're welcome, you're welcome. Thank you for your continued support and commitment. We wish you all a lovely day ahead. Please note a poll will be coming up on your screens shortly. Kindly respond to the polls. It gives us, your responses give us an idea of how to make these sessions more engaging for you for the next time. Also, we will send you an email with all the webinar resources, the presentations from the two presenters, responses to questions that may not have been asked out here, and the webinar recording. Everything will be shared with you, along with a certificate and 5 CME points for those who it applies to. A quick plea before we go that Only participants who register with their correct names and Zoom IDs will be eligible for the 5 CME points and the certificate. So sharing your Zoom links causes a lot of duplication of names on the attendee lists, which may affect the eligibility of those that attend. So to ensure fairness, we strongly discourage this practice. And thank you once again. My name still remains Margaret Wisdom, your moderator. It's been a pleasure having you here. Thank you and have a lovely day ahead.
Thank you. Good.